So my name's Rachael Geddes. I'm the Autism Practitioner for the Child Health and Disability team based in Inverness and covering Inverness, Nairn, Badenoch and Strathspey. And I'm also the training coordinator for neurodevelopmental services for Highlands. My background is as a learning disability nurse, and my passions are challenging behaviour and sensory processing together, along with the anxiety that children experience as part of their profile. So I'll just hand over to my colleague, the lovely Lesley Soffe.
I thought you were going to say glamorous, and I was going to
Glamorous, very glamorous.
Kind of was for a change. Thank you, Rachael. Good morning, everybody. I can't quite believe how many of you are here. So yeah, not only be kind to Carrie and Alison, but be kind to me and Rach too, please. So I'm Lesley Soffe. I'm the Advanced ADHD Nurse Practitioner, and I'm team lead for a small team of nurses, nursery nurses within Highland. We cover the whole of the Highland Council area, so everywhere except for Argyll and Bute, which does come under NHS Highland but isn't actually part of the council area. I kind of mostly in my role deal with the most complex of patients that have a diagnosis of ADHD but usually have an additional or more than one additional diagnosis as well. My background is I'm a children's nurse, paediatric nurse by training, and then have done kind of a Bachelor of Science in Nursing Studies and a Master's in Advanced Nursing Studies focused on ADHD and mental health in children and young people. So yeah, that's me in a nutshell, and I shall get Rachael to pop us onto the next slide.
Yeah, and Lesley and I frequently work together over some
and
of the most complex children in Ireland.
Complex presentations, yeah, exactly. So it's really nice to do this with you, Rach. So we're going to kind of, I suppose, give a bit of an overview about how complex presentations come along to us in our services, and then how we would maybe manage those children and young people. But the first thing I suppose we want to touch on is the Neurodevelopmental Assessment Service, or NDAS, and I'm sure lots of you have come across NDAS, whether your children have been referred or whether you've referred children and young people on your caseloads into that service, and that's where all children and young people within Highland would be referred to if the people involved with them and parents or carers thought that that young person had a neurodevelopmental difficulty of some sort. Depending on that referral would depend on which professional group you saw when you came for your first triage appointment. So there's combinations of professionals working in our service. There's obviously community paediatricians, speech and language therapists, occupational therapists. We have access to psychology. There's the ADHD nursing team and various other individuals along the way as well. But neurodevelopmental difficulties, I suppose we want to kind of think about how they affect our children, and then how we can look at the most complex of those cases. So neurodevelopmental difficulties can affect the way that our children and young people develop and learn. These difficulties can affect different aspects of their lives, and that's kind of the most important thing for us as practitioners trying to help these young people, is what parts of their lives are these difficulties affecting, and how can we kind of tailor the care plans that we create to help these young people and support these young people. So the areas that we look at are independent skills. So that's kind of thinking about whether a young person can manage tasks independently, or do they need support for things. For example, do they need more support than you would expect for another child of a similar age and stage? So it's kind of trying to work out where they're at. So I think that's one of our kind of biggest skills probably, is that we're quite good at knowing what is expected of a child at a different age and stage, and then kind of thinking, right, okay, they're not where we would expect them to be. Motor skills, so a child or young person might have difficulty with gross motor skills. That might be things like learning how to ride a bike, throwing and catching balls. They might have difficulties with fine motor skills such as handwriting, kind of more smaller kind of tasks that they might find more difficult. They also might be quite motor restless. They might be fidgety. They might need to move around a lot, and they might need to do that things in order to concentrate and focus on other aspects of their learning. We've got communication and social interaction. So a child and young person might struggle with making friends. They might find it difficult to read other people's emotions. They might find it difficult to understand their own emotions or regulate their own emotions. So that's a huge area that needs to be looked at. Play and flexibility, and also sensory and regulation. So children and young people could be very rigid. They might have quite fixed obsessions or things that they want particular interests. They might struggle to join in with group games, for example. They might find it hard to understand rules of games. They might have particular sensory challenges. For example, they might struggle with loud noises, different textures, touch, taste, smells. They might have really restricted diets. So all of those things would come under that area of difficulty. Academic and learning. So again, we would be assessing whether a young person might have a different learning style, whether they may need things presented in a different way. They might need visual aids, they might need visual timetables. There's lots of things that could be looked at within that, and where they are academically. Are they where we would expect them to be in all aspects of their learning? They might need things like workstations, wobble cushions. There's lots of things that we can do to help children and young people with their academic abilities and to reach their potential. So the other thing I suppose to think about there is whether a young person with a neurodevelopmental difficulty could also have a learning difficulty as well, and it's much more likely for a child with a neurodevelopmental condition to have additional difficulties like that. So for things, for example, like dyslexia, dyscalculia, and those areas of learning difficulties. Attention and memory, organisation and planning skills. I suppose for me, this is kind of a big area of what I look at when I'm going out to assess a young person for things like ADHD. So a child or young person might have difficulties maintaining focus, their concentration. They might struggle to follow instructions. They might struggle then to process the instruction and actually carry out the task. They might have very poor working memory. So their long-term memory may be absolutely fine, and they might remember things from when they were tiny in great detail, but their working memory, the memory that they need in order to carry out a task, remember what's been asked of them, can be quite poor. They might forget what you've sent them through to their bedroom for example. They can lose things very easily. They also might have difficulty with recall. So your working memory is what you need in order to remember, something that you've learned. So if they were getting asked something about mental maths, that's their working memory that they would need in order to recall that learned material. A child and a young person might also struggle with their organisation and planning skills. So they might find it difficult to know what they need to take to school for a certain day or for a certain subject. They might not know how to plan out an activity or a project, especially when they're in kind of secondary school age and that kind of area. The emotional and well-being part of their neurodevelopmental assessment is also really, really important in their mental health, because children with these difficulties are at much higher risk of having emotional challenges, whether it's they struggle to manage their emotions, they might suffer from anxiety, they might feel overwhelmed a lot of the time because they have got a lot to kind of manage on their own, and they're often lacking on self-esteem and confidence. So it's really important for us to assess that and make sure that these children are really well supported. And the last kind of area that we would assess and look at is attachment and relationships. So again, children and young people with these conditions are likely to struggle with relationships, and having neurodevelopmental difficulties can put stress and strain on families as well. So we have to bear that in mind. We also know from research that children and young people with attachment difficulties and developmental trauma, which we're going to touch on later, are much more likely to have neurodevelopmental difficulties as well. So we all have to bring that into our assessment and see what the kind of background is for that child and family as well. So that is NDAS and what we're looking at within NDAS in a nutshell, and I shall pass over to Rachel for the next slide.
Okay, so an NDAS diagnosis often looks for a specific condition, or children can come out of NDAS with a series of conditions or an unspecified condition. So when the difficulties are really significant and it can be part of a specific diagnosis, some of the things that are often diagnosed as part of the NDAS system are ADHD, autism, developmental coordination disorder, fetal alcohol spectrum disorder, a sensory processing disorder, and a developmental language disorder. Now, interestingly, in Highland, the recent statistics tell us that 24% of those children that went through the NDAS service came out with no diagnosis. That is not to say that they didn't have problems, because clearly they'd been referred for a specific reason. They were struggling over something, but it wasn't part of a specific condition. Now, I've recently come across one particular child who was diagnosed as ADHD and having neurodevelopmental difficulties non-specified, because he'd sort of got little bits of everything, but not enough of anything to be really able to clearly say what it was. So his diagnosis, ADHD and neurodevelopmental non-specified. Okay, so we often work with children who've got combinations of these conditions. So Lesley and myself work together very frequently over kids who've got both autism and ADHD, but we also tend to see with those children that they've got high anxiety levels, they've got some sensory processing difficulties, and they may have some DCD type symptoms as well. So there's nothing really clear cut. You know, when you think about a child, every single child is different. So therefore, trying to squeeze a child into a box is not always possible. And it may be that they might need to be in 2 boxes or 3 boxes, or it's difficult to tell which box they fit into. We were talking before we opened the course about sort of hybrids of different things, because no one thing is always the same. So we were actually having a very informative conversation about donuts and the recent introduction of cronuts and bronuts, which are croissants and brownies combined with donuts. So he's thinking about a child as being an individual. They aren't just one thing. They might have a spectrum of different conditions, and that looks different for every single child that you work with. I've been working with people with learning disability and autism for 32 years this year. And I've never met 2 people the same. So it's always, when we think about complex presentations, it's, you know, pretty much every child has got their own presentation of whatever set of conditions that they've been diagnosed with. And Lesley's going to tell you a little bit more about why we often see autism and ADHD together.
Thanks, Rachel. I think I would completely agree with everything that you said there, and quite often actually lately we have been finding it quite difficult with some of the young people that have come through the neurodevelopmental assessment service to give, you know, a really clear diagnosis. And I think we are using more of the kind of, or more commonly now, or more frequently using those umbrella terms such as neurodevelopmental condition unspecified or pervasive developmental condition. So I think it is exactly what Rachel's saying, is we need to look at these children and young people as individuals, and then our assessment and our treatment plans, management plans, need to be individualised, and they need to be changed and, you know, kind of modified as that child grows, because the conditions change as the child grows and develops too. So within kind of the diagnostic criteria, I suppose, for kind of the main conditions that we do look for within the neurodevelopmental assessment service, there are traits that overlap. And particularly in autism and ADHD, they're both very highly heritable conditions. So with ADHD, it's about 75% heritable. So when we're looking at an assessment, we're asking the families about their kind of, who else is in the family that's like this child? You know, they might not have a condition that's been diagnosed, but is there somebody else that is very similar to them in characteristics? Or is there people within the family that have diagnoses of ADHD, autism, or other neurodevelopmental conditions? Because we can most of the time trace those conditions back through the family. So you've got that predisposed heritability to having ADHD and autism. And there's lots of crossover in features between the two. So, for example, you know, we talk about anxiety a lot. Anxiety is very present in both of these conditions. But there's also things that are, you know, we can say that are slightly different as well. So anxiety is just one example, but there are, they quite often both show features of sensory difficulties, you know, finding it really difficult to manage noise, smells, texture. They both quite often have difficulties with social situations and managing friendships and relationships. So we do have to kind of really look at the, I suppose, assessment and make sure that we are diagnosing correctly, or, you know, do they have both? Because it is common for children to have diagnoses of both. So we think around 30 to 50% of autistic children would get a formal diagnosis of ADHD in addition to their autism diagnosis. And certainly within Highland, for myself, when I've done kind of audits and looked at the kind of statistics, at the moment, or the last time I did an audit, which was a few years ago now, there was about 25% of children in Highland who had an ADHD diagnosis, but also had an additional diagnosis of autism. So, you know, that's quite a high percentage, and that's why it's really important for us as practitioners to work together. So Rachel's got lots and lots of experience 32 years of working with children and young people with these difficulties. And therefore, for me, when I'm working with some of the patients that I've got that have got multiple diagnoses, it's important for me to get Rach on board and help me to think about things from that perspective rather than just through an ADHD perspective. And obviously we've got some understanding of both conditions, but that's where Rachel's main focus is, whereas mine is more around ADHD. So it's really, I suppose, genetics do come into these conditions a lot, and that's why we will ask questions about family history within those assessments. So, although I'm saying that, and we're saying about these assessments and looking very carefully, it's not always very clear cut, because lots of children and young people that come through the neurodevelopmental assessment service have also experienced other difficulties. So trauma, for example, can have a significant impact, and particularly if that trauma has happened at key developmental stages. So if there's been a kind of significant trauma when a child's a baby, or when they're a toddler, or when they're about to transition into primary school, these can have a significant impact on the way that that child has developed and can look very much like other neurodevelopmental conditions. So developmental trauma in particular, and attachments, which is the next one, particularly insecure attachments, look very like ADHD. So that for me, when I'm doing an assessment, I have to kind of have that detail from the family history and the developmental history from the family about what else is going on in that child or young person's life, because they can look so similar. You know, a child with an insecure attachment can look quite hyperactive, but it's more about they can be quite hypervigilant and anxious. Sorry, I can't get my words out. So they can look like they're flitting around and restless, and they are, but in a different way. They can also have difficulties with relationships. They can also have difficulties with emotional regulation, certainly with trauma and attachment difficulties. They often have difficulties with that ability to regulate their emotions. So we need to make sure that we're looking properly at the family history and the background so that we're given the right diagnosis. Because if a young person has had trauma and insecure attachments, it doesn't mean they can't have a neurodevelopmental condition as well, but those would need different types of support and management going forward. And bereavement is another one. You know, it can cause a massive impact on a child or young person if they've suffered bereavement at an early stage, and depends where they are in their bereavement journey, you know, whether they've managed to kind of process that and the impact that can have again on them emotionally and behaviourally. So we need to think about these things and whether they are having part or playing part in what you're seeing from that child, because all behaviour is a method of communication. So we need to know what it is that child's trying to communicate to us. So it's really important for us to kind of make sure that we've got the big picture. I'm going to pass over to Rachel to talk a bit more about kind of developmental delay, because that's more, she knows more about that than I do.
Thanks, Lesley. So yeah, we also have things like global development delay, where children are not at their expected level of ability within their peer group. We can have learning difficulties such as dyslexia, or we can have a learning disability. On the next slide, I'm going to go over those in a little bit more detail. But firstly, we also wanted to add in here at this point the effects of the COVID crisis, because the last couple of years have had a significant impact on the social and emotional development of some children, particularly very, very young children, because there hasn't been that capacity to socially interact and have social communication at the same sort of levels that we would expect within, you know, out with the pandemic. So that's been had quite a knock-on effect on some young children who are struggling now with social interaction in nursery and social communication, because they didn't get that early exposure at things like play groups and mums and toddlers and things like that. So they didn't have that early access to a peer group. You know, I've been talking to parents whose 1-year-old child has never met its grandparents because they live in another country or they live in a different part of the country, and it's been so difficult with the COVID regulations. So it's been a very strange time that we've lived in over the last couple of years. So that has to be brought into play as well of what we're currently thinking about.
We're also thinking about how, sorry Rachel to interrupt, we're also thinking about how we assess that going forward into ENDAS, because we're thinking in a couple of years' time we'll have these children and young people coming into the service, and we need to think about how that lack of opportunities to develop maybe some of the social skills has had an impact on them, so that we can kind of make sure that we're not kind of I suppose judging them or making a diagnosis before taking that into account. So I think we're already thinking that that's going to have a massive impact in a couple of years' time.
Yeah, I think that's very good to say, Lesley, because it is having an impact. It's also having a significant impact on some children's mental health and their anxiety, of rules and what we can do, what we can't do. The changes in regulations has caused significant anxiety for some children, and those children could be completely neurotypical but might now be presenting with these anxiety issues that are not a neurodevelopmental basis, or there could be children who've got neurodevelopmental difficulties, which we're already aware of, whose mental health and anxiety has been impacted by this crisis. So I just want to do a little bit of clarification, because there seems to be a lot of confusion about this one. I've recently advertised a course for parents of children with learning disabilities, and I had loads of parents apply to it whose children had learning difficulties. So as part of this, I just wanted to clarify what is the difference between a disability and a difficulty when it comes to children with neurodevelopmental difficulties. So technically, a learning disability is an IQ of less than 70. Now, frequently in Highland, we do not IQ test children. It's very rare that this actually happens. So it has to be on professional judgment whether that child has a learning disability. And within that, we are talking about those children who are really struggling to learn and grow at the same rate of their peers, and that this is having a significant impact on all areas of their life. So if we think about the autistic children, 40% of autistic children also have a learning disability, and this can range from mild to severe. And around 25% of ADHD children also have a learning disability ranging from mild to severe. So how does that differ from a learning difficulty? So a learning difficulty is about something that makes it harder for you to learn. Okay, so you have an average IQ, or you could also have an incredibly high IQ, so average to high IQ, but you have autism or ADHD. Okay, so their IQ is not impacted, but they might have an inability to concentrate, focus, relate to others, become easily overwhelmed, be anxious, or have sensory overload. Okay, that doesn't mean that they can't learn. They have an average to high IQ. They might need some additional support within school in order to be able to help them to focus and concentrate and get the work done in an appropriate manner. We also see that some children, both with neurodevelopmental difficulties and without, can also have problems with dyslexia, dyscalculia, or developmental coordination disorder. Those are learning difficulties. They are not a learning disability. So just because a child is autistic or has ADHD does not always affect their ability to learn. Many of my caseload have gone on to attend college, to do standard grades, hires, some of them have gone off to university. The majority of the children that I've worked with over the years without the learning disability are now in work. Some of them are married. So there is a difference between a disability and a difficulty. For those of you that are my sort of age, the learning disability would previously be known as mental handicap. Okay, so that's what learning disability is. And I think there is a lot of ambiguity between the two terms, but I just wanted to clarify that today, because I say I have been approached probably by about 30 parents in the last month trying to attend a learning disability course when their child had autism, and I've had to try and clarify with them whether their child is autistic with a learning disability or autistic without the learning disability. So if we think about individual children, no matter how complex the child's difficulties, we have to think about how we are going to help that child, because that's the most important thing. The labels give us some way of knowing what might help that child, but realistically, every child is an individual. So what one child is going to experience is not the same as what another child is going to experience. And we have to help the team around that child and that child's parents to understand the specific needs of that child rather than that condition. Children should never be seen as a condition. They are a child who is autistic or who is ADHD, but they are their own person, okay? So we as the adults around them need to assess and break down what the difficulties are in relation to 6 areas of development. And this is what we really need to focus on. No matter how complex the child, these are the basic things that we need to keep coming back to think about where is this child's difficulties in this area? What is the problem? How can I help them to make this better? What sort of things can we put in place? So as the neurodevelopmental training team, in conjunction with the educational psychology team for Highlands, we have developed a 6 pieces of pie strategy of how to help children with any neurodevelopmental difficulty, whether it's diagnosed or not diagnosed. This system will work for every single child. Okay, so if you have not encountered this system yet, it is available via the Pines website. There are 6 individual films about the 6 individual pieces of pie, and there is also an assessment document that can be used within schools to look at individual children and put a plan together about how we are going to help them. Okay, so those are on the Pines website. We're just going to give you a little bit of an overview this morning of the sorts of things that are in them within the 6 pieces of pie. However, if you are a parent of a child with a neurodevelopmental difficulty, or you're a member of staff who's working with children with neurodevelopmental difficulties and you're feeling a bit stuck and you're not quite sure where you go in or what needs to be done for that child, then I would highly recommend watching these 6 films and using the assessment documents to think about how they can be helped. We've also been in consultation with the NDAS team, and if you had a child that's been referred to the NDAS team and you do the 6 pieces of work and do the assessment document, the NDAS team will accept this as part of the referral, so it's well worth doing. But it also, you know, we talk about NDAS a lot, and all of us will know that the waiting list for NDAS is incredibly long at the moment. So this is how we can start to meet that child's needs without a diagnosis, yeah, because they're a child with needs. We don't need to wait for a label to be stuck on them. We need to start figuring out what we can do to help them first. Okay, so I'm going to start with the communication piece of pie, and then I'm going to pass you back over to Lesley.
I think I've got communication, Rach.
Oh, have you, darling? Sorry.
Yeah, that's all right, if you don't mind. I don't mind.
You go, my love.
Okay, lovely. No, Rach is right, and I think it's really important actually that, you know, thinking about the neurodevelopmental assessment service is undergoing just now a huge hopeful change, and things are going to change and hopefully improve for the future. But I think in the meantime we do need to just think about how we can best support these children and young people so that we're not reliant on a diagnosis, because I've heard that lots over the years, you know, say, well, we can't put any support in place until they've got a diagnosis. And that's not true, that we can put lots of support, or, you know, the people involved with that child or young person can put lots of support in place when we're waiting for that diagnosis, or thinking about that diagnosis. And actually, sometimes for us, as part of the neurodevelopmental assessment team, it's really useful when a referral comes in to know what's been put in place and to know what's been tried, to know what's worked and what's not worked, because that can help us with our assessment and make things much clearer as well. And that's what we do, you know, when we're then hopefully working with these children and young people after they've been through the assessment process and have had a diagnosis or not. We can make recommendations, we can be involved if it's appropriate, depending on, you know, what their diagnosis is. And we think about these pieces of pie, and I now all I can think about is cronuts and pie, and by the lunchtime I'm going to be starving. But you know, it's important. Honestly, it's in my head all the time. So I think we just need to think about each child, as we said already, as an individual. No matter how complex their presentation, we still, as practitioners working with these children, break it down into those 6 areas and think about what's the best things we can support. So with communication, how that would maybe present in a child or young person is that they might struggle to follow instructions and rules, particularly in ADHD. That can be a big area of difficulty. So we can look at how do we manage that? You know, do we need instructions broken down into bite-sized chunks? Make sure that they're not complex and vague, you know, they're very clear. They might be off task because through their behaviour they might get really distractible. They might then be disruptive within the classroom environment. They might be slow to get started on work, and it can look like they're procrastinating, but actually they're not sure how to start. So that can be something to actually, is it that they're not sure what they need in order to start? Do they need a pencil? Do they need to know what page they can have to turn to? But they quite often don't want to ask for help because they don't want to kind of stand out. They might disrupt others because of their behavioural difficulties. They might not engage because they know it's going to be hard. You know, these children we've talked about usually have normal IQs or high IQs, and they understand that sometimes things are hard, and in order sometimes not to fail at a task, they just won't try because it's horrible to keep trying and failing, you know, so sometimes they just opt out. They can become quite distressed. I've just said that, opting out or withdrawing because of how that feels when things are difficult for them. They might not get their homework done, and that can be a bane of contention in the home environment. They might gesture, point, rather than saying what it is that they're struggling with or what they need help with. So we then look at the profile of that and thinking about, well, what's going on here? Is it about difficulty understanding maybe language or non-literal language? Have they got a difficulty processing the language? Does it take longer for them to process an instruction because of, you know, often with young people with ADHD in particular, they have a slow processing speed, so they need more time. And are we giving them that time, or are we saying, come on, hurry up, get a move on? They might only pick up fragments of instructions, particularly if they've got a concentration difficulty. They might only have heard the last bit that's been talked about, or a bit in the middle, or a bit at the start, because they've lost that focus. They might be unable to take the meaning from non-verbal aspects of communication, such as gestures or facial expressions. They might misunderstand the tone of voice that somebody's talked to them in, or the volume. And quite often with ADHD, they have a difficulty with volume control, so they can feel like they're shouting at you, but they're not aware that it's louder than maybe it would be with another child. They might have difficulties expressing themselves, so they might have limited vocabulary. They might struggle to structure sentences. They might have echolalia, where they repeat certain sayings or things over and over again, or they might repeat what other people are saying. They might have stereotype use of phrases. You know, a lot of young people that I see actually speak in an accent and things as well, so there can be things like that, or they repeat things off of television programs that they've seen. They might blurt out the first thing that comes into their head. Particularly my patients with their ADHD are very impulsive, so they might shout out the answer before the question's finished, or just want to tell you something and that's been shouted out, and they've quite often got no filter, so it comes out just exactly as they've thought it straight away and not really had the chance to think, is that an appropriate thing to say, or is that going to offend somebody? They might find it difficult to find the word that they need. You know, sometimes it's hard just to find the word. They might struggle with speech sounds, and they might mumble. Quite often young people with these difficulties have difficulty in pronouncing things, or they might speak too quickly, and then it gets really hard to kind of hear what they're trying to tell you. And they might be a reluctant speaker. They might have lots of anxiety, and then they might kind of not want to speak, or they might be quite they might have difficulties around that. So what things we can do to help in that situation would be kind of face-to-face, making sure we're getting down to their level if they can tolerate that. Some young people with these difficulties can't, so we just have to be aware of that. Making sure there's lots of opportunities to play and talk together, giving them a chance, pause and wait, particularly with young people that have difficulties with processing speed. We need to give them that chance to carry out what we're asking them to do. Copy and add words, and being careful with our questions. So, you know, again, with instructions and not making it a question, that's one that comes up with ADHD a lot, is we can say, do you want to put your jacket on? Nah. Do you want to do your homework now? No. You know, it's actually, are you giving them an instruction, or are you giving them a choice? So being careful about that. So what we should do is use visuals wherever we can, because that helps support the communication. And they respond, lots of these children respond really well to visual aids and visual timetables. Reduce your language. Don't explain things too much and be long-winded about things, because they're going to lose the focus. They're not necessarily going to understand. Think of the language that you're using. Be aware of idioms, metaphors, sarcasm. Are they too literal? Do they understand those things? Be aware of non-verbal use of language. So if we're expecting them to understand something that we're doing through gestures, giving them that processing time, thinking about background noises, particularly we're going to look at sensory difficulties, but are they going to be overwhelmed with things? What's the volume level like in your home or within the school? Is there lots of things going on that could mean that they get overwhelmed? And think about where your child is sitting in relation to you, and don't making sure that they're in a place where it is going to be easier for them to kind of listen and hear and process and follow those instructions. And that's very important in a school environment. Often I go in to do school observations, and the child that has difficulties with concentration and focus and being distractible is at the back of the class, beside the window or beside the door, and there's lots of distractions, so it's really hard for them to focus. So think about where they are positioned in the classroom, or even when you're trying to talk to them at home. And don't, for example, talk to the back of their head, because they won't know you're trying to talk to them. So there's lots of things that can be put in place to kind of help support around communication. And I think it's me for the next one too, Rachel.
It is, Lesley. I'm just going to add in there that if you're struggling with pre-verbal children, or children who are really struggling with communication, one of our fabulous speech and language therapists, Sharon Smith, who runs the Words Up project for Highland, has put all of these details into film, which again, if you go onto the Pines website and you search up Words Up, it will take you to those 5 films to help you to support communication. They're absolutely excellent.
There's just so many really useful strategies and films on the Pines website, so you really should check it out and have a look at everything that's on there, because there's such a wealth of resource for you to kind of use. So we're going to move on to kind of cognitive, so thinking about how they're kind of processing things, thinking about things, and how that might present. So they might struggle to do their homework because quite often with attention spans and things, obviously homework's going to be difficult, but there's also a little bit about having to do schoolwork at home and how that doesn't sometimes necessarily fit with, logically. So it can be quite difficult for them to separate what they do in school to what they do at home. And often these kids are working really hard to hold things together all day within a school environment and work really hard at being there and managing all their difficulties. And when they get home, they just need to release a lot of that. So then in order for them to do homework, they have to kind of try to refocus and think, oh, what do I need to do now? So that's a very difficult task. They might not be able to pack the right kit in school for bag, because again, cognitively, they are struggling with those organisational skills and the ability to plan. And we do a lot of work, or certainly I do a lot of work with when young people are going into secondary school and they've all of a sudden got to manage 8 different subjects with 8 different teachers, and get from, rather than being in one classroom all day, they're now in a massive environment and they've got to get between different buildings for different times. And it's a huge organisational task. So we look at ways of trying to improve that for them, whether it's colour coding timetables and making sure they've got each subject in a colour coded pack so that it's easier to remember what it is that you need to take with you. They might have difficulty with multi-step activities. So again, are they able to carry out lots of multi-step tasks in a oneer, or do they need that broken down? Are we asking too much of them cognitively? Is that just too big a task? And do we need to break that down into smaller steps for them, or one at a time? They might present with impulsive behaviours, and often my young people do present with impulsive behaviours, and that can mean lots of things. Can be shouting out, can be interrupting, can be intruding on others, can be risky behaviours. That can be lots of things. They can rush at tasks, so some part of that's just they want to get it done, but they can be a bit careless and make mistakes because they're not taking that time. Because certainly for my young people with ADHD, often they think, oh, I must just do it now while I remember, and they just try and get through it, but then it can lead to lead to them making mistakes. They can be off task through behaviour, and they're easily drawn into things a lot of the time. So they might not be the one that's initiating any misbehaviour, but they just get easily drawn into it because they're so distractible. They'll often have difficulty filtering out background information, and particularly with ADHD and with autism as well, when they can be overwhelmed with sensory things. But everything is as equally overwhelming in ADHD, and they do find it really difficult to filter out all of those external noises or interruptions, but also internal things. Are they worrying about things that have happened, whether it's at home or they've had a run-in with somebody in the school corridor, and they can't kind of filter any of that out, and it's very overwhelming, and then it's hard to focus and hard to pay attention. And they can be slow to get changed or organised for activities because, again, it takes them that bit longer. It's a more complicated task for them and they do need that bit more time. And they forget everything. My patients forget everything. Like I've had kids that have lost 3 school jumpers in a week, and they've lost their iPad. They come home with 1 shoe. I don't even know how can you come home with 1 shoe? But you know, they really do struggle with working memory, but they can forget to charge the Chromebook. So when they get to school, the teachers, you know, they do a lot of work on Chromebooks now, and they're saying, is your Chromebook charged? No. And do you have your charger? No. So, you know, that can lead to kind of difficulties as well. So the profile of a child with cognitive difficulties can be that they present as having difficulties with organisational skills. They struggle with problem solving, so they need support in order to try and work out how to manage a difficulty or a problem that they're having. So they do struggle with that. They might have difficulty with flexibility of thought and be quite rigid in their thinking and quite black and white. And then that can lead to kind of behavioural difficulties or challenges. They might be controlling, they might be kind of inappropriate impulses. Controlling, and quite often people will say, oh, this young person's quite manipulative and controlling, but actually it's about anxiety, and they've got a really, if you think about it, a lot to manage, and their environments feel chaotic and out of control, so they will try to control it to make themselves feel better. They might have inappropriate kind of impulsive behaviour, and it might lead to kind of behaviours that can be, I suppose, perceived as being annoying, like tapping or banging or making noises, but they can't help it all the time, you know, so sometimes that is a bit, they just can't help it. They might not even be aware of it. And they obviously have difficulties with attention and maintaining that focus, sustaining the attention and switching. So transitions are particularly difficult, that they then might be really focused on something and then we're expecting them to stop that and start something else. So how do we help them manage that and switch from one task to another? So that can be difficult. The things that we can put in place to support children with their cognitive difficulties is structure and routine. You know, children with neurodevelopmental conditions, particularly autism and ADHD, really benefit from having clear structure and routine and knowing what's expected of them. And of course, there's always going to be things that happen that are unexpected, but where we can, we try to make things as structured and routine as possible and have those visual supports and visual aids in place so that they can look up to the wall and they know what's happening next, or they know what's happening after lunch. And visual or written checklists for routine activities, so they can check what's needed that day and what they need to do. They might have visual or auditory cues for change, so prompts. We need to give them warnings of change a lot of the time. If they do find the difficulty of the switching or transitions difficult, can we count down to that? Can we make sure that they've had plenty warning before it happens? They might need a running commentary of problem solving to help them to support their understanding. So we need to be, I always talk about scaffolding, and Rachel always talks about underpinning, but we talk about the same thing, about making sure we, as the people around these children and young people, help them learn those skills. So if we have to talk through that problem solving with them, that's going to help them learn that skill, and use problem solving scripts so that they can kind of work through that. I quite often use traffic lights, for example. So we have red, what went wrong, you know, describe what happened. Amber, what could you've done? What, you know, and they can come up with lots of ideas, and they might be ridiculous. Like if they're having a fight with somebody, they might want to shut somebody in a cupboard. But you can then go through all of those and say, would that work? No, probably not, because you're going to get then in trouble for doing that. And when you come up with a solution, that's green, and next time they try it out. And Chromebooks, actually, although I'm talking about them forgetting their charger and not having them ready to use, are really useful for children with neurodevelopmental conditions. They respond well to IT and computers. It works for their attention span. It's really fast and gives them immediate feedback, so they keep engaged with it. So it can be really useful. I'm going to hand over to Rachel for the next slide.
Thank you, Lesley. I just add in at this point is, if your child has lots and lots of these difficulties, we have a full film about executive functioning and flexibility of thought on the Pines website, called Supporting Your Child to Cope with Change. Maybe Carrie, could you put the link to that in the chat, please, so people can get to that one, which gives you loads of ideas of what you can put in place for children. Okay, so the next one we're going to consider is motor, and this is me. Okay, I have tons of motor problems, and unfortunately I grew up in the 80s when DCD had never been heard of, so I never got a diagnosis. But when I look at the DCD criteria, I could hit 99.9% of it. So motor difficulties for children can present as that child being clumsy or awkward. They might have challenges with focusing. They might struggle with things like self-care. So can you do buttons? Can you do shoelaces? Or is that a massive struggle when you're getting dressed? My son was actually diagnosed with DCD last year, which even more convinced me that I have it myself. And it took him till he was about 11 before he could tie his shoelaces. Does your child have difficulty organising their belongings? Again, they might be losing things. Are they using too much or too little pressure? So have you got a child who every time they try to write with a pencil, they break the lead in it? Or when they give you a squeeze, they're literally squeezing the life out of you? Motor activities can take more effort for these children, and they can get tired very, very easily. They might bump into things and they might fall over. So what would we be seeing in the profile of a child with motor difficulties that have got a neurodevelopmental background is they might find stabilising things such as pencils challenging. Their joints might move more easily. For anybody who's had the pleasure of trying to read something in my handwriting, you will know it's absolutely shocking. They might struggle with slower motor activities, or might not be able to manage some motor activities. For instance, the catching, the kicking, the hitting with a bat. I was chronically bad at sport. I've never been able to do a handstand in my life. I can't even do a roly-poly. So kids need time thinking about these skills, and it looks more effortful. So you need to think about the fine motor skills regarding doing a puzzle or doing Lego or doing hammer beads, those sorts of things. It's likely to be incredibly difficult for them. And then the gross motor skills of managing your body in an appropriate way. So that would be that you're not walking into things or dropping things or missing things when you're putting things down. So how can we help these children that we think have got some motor coordination issues? So we can think about where they're sitting, whether the table and chair are at the right height. We might put a box under a child's feet. Say, for instance, you've got a small child in your classroom who their feet don't touch the floor. Actually having their feet on a box underneath the table will really, really help them. We might think about only allowing, well, not only allowing, but suggesting to that child that they wear sturdy shoes. This can be really helpful for some children. I certainly walk better when I'm wearing boots than I would if it was something really flimsy. Don't ask the child to sit on the floor without support. So if those of you that are teachers here today, if you're doing things like story time or planning time and you're all sat on the carpet together, please allow that child to sit up against each other. I thought it was completely normal to have excruciating backache at the age of 10, and it's not. I've now discovered why I've got those problems. We might need to assess and monitor the seating. Oh, and I look like I've actually duplicated myself on there, so I will jump on to the next one because you don't want to hear me say it twice. I must have got very excited with the cut and paste at that point. So sensory. I'm really passionate about sensory difficulties for children with neurodevelopmental difficulties. A few years ago, I did a master's in autism, and one of the questions asked me what had changed since you came into practice. So I came into practice of doing my learning disability nursing training in 1990, when sensory processing difficulties were not recognised within the autistic diagnosis. We knew that people had got some sensory difficulties, but it wasn't focused on as much as it is now. So I chose to do one of my modules all around sensory processing, and it was just incredible the difference you can make to a child if you can focus on their sensory needs. So they might have strong responses to things, such as, they might have a lot of auditory overstimulation to things like smoke alarms or the school alarms. They might have real difficulties with visual things, of being very overstimulated by visual information, finding it really hard to look at a whiteboard because there's loads of visual information on the sides of the whiteboard. They might not be able to filter out background noise in order to be able to concentrate. They might have problems with something called proprioception, which doesn't get talked about nearly enough in my humble opinion. So proprioception is about your ability to feel your body as a concrete thing in space. So for instance, I'm sat at my desk at the moment. I can feel my bottom on the floor. I can feel that my feet are in different positions on the floor, and I can feel my elbow on the table. I can also feel that my thumb is propping up my head. My handbag is just underneath the table, and I could reach down into that and find my mobile phone without any problems because I've got good proprioception. Lots of children with neurodevelopmental difficulties don't have good proprioception, so that leads to a really high level of anxiety, because it's like shaking a can of pop the entire day. They just get more and more anxious because the feeling within their body is not working properly. So those children will be really fidgety, they will be swinging their feet about, they'll be rocking backwards and forwards, they'll be jumping up and down. When they sit next to you on a settee, they might be on your knee. Those sorts of things. Those sorts of children are also might have difficulties with interoception, which is your internal sense, which looks at, am I hungry? Am I thirsty? Am I full? Do I need a wee? So if you've got problems with proprioception, you're likely to have problems with interoception as well. So lots of children have difficulties with taste and textures of food due to their sensory processing difficulties. They might really struggle with clothing. They might over or underact to pain. I've known children to break a bone and not actually tell you that they've got pain anywhere. And to the other end extreme, you could touch a child lightly and that might be incredibly painful for them. We often see a lot of that with teeth brushing, nail cutting, hair cutting and hair brushing and washing. It can be really, really quite uncomfortable and painful for some people with neurodevelopmental conditions. So what would the profile look like? Well, the experience of sensory differences is highly individual to each person who has these problems. So some children have hypo-responsive conditions, so they're not reacting as strongly to sensory information, and some children can have hyper responsive reactions, which means that they're experiencing it far stronger than everybody else. So for instance, a young man said to me, it was just before COVID, so a couple of years ago now, this young man was telling me about how it really irritated him when his mum put washing on a radiator, because he could literally hear the water evaporating out of the clothing. And he'd never thought to mention it to mum because he thought that we could all hear it. So we was, we get many damp days in Highlands where you can't put your washing outside, so mum was popping them on the radiators, and we just came to the conclusion that if he had one room where there was no washing on the radiators, he would be able to cope much better. So that became his bedroom. So we need to, when we're thinking about planning how to meet a child's individual sensory needs, there is a film within this, the 6 Pieces of Pie, so I'd highly advise that you watch that. That's being done by one of our OTs. And there is also an additional film that I did as part of my master's programme called Frazzled Fred, and that comes along with a booklet outlining all of the sorts of things that you can do to help your child to overcome some of their sensory difficulties. So some examples might be that if you have a child who is very overstimulated by fluorescent lighting, that when they have to go somewhere, if they have to go somewhere that's got fluorescent lighting, that they either wear sunglasses or a baseball cap with the lip at the front so that they're not overstimulated. There's also loads of details within those films about how to use deep pressure to help children with proprioceptive difficulties, and offering regular movement, because that will really help them. And I think I'm handing back over to Lesley for social.
Yep, and I think then we're getting towards the end. This is our second last slide, so we maybe are running over time, but we will try to make sure there's plenty of time for your questions at the end as well. So social, again, we're thinking about, you know, kind of relationships, peer relationships, and how they read social interactions and how well they manage those communications and interactions with peers or parents or anybody. So they may present as being socially isolated and kind of keeping themselves to themselves, or withdrawing from social activities that they find particularly difficult. You know, often we see with group activities that they really don't manage that very well, so they will try to opt out of those. You know, quite a lot of our patients will be found standing in the stairwell in secondary school because they do find, especially the busy times of day, break times, lunch times, really difficult, so they kind of will isolate themselves when they're struggling with that. There might be peer conflict because, again, they're not quite reading the situation properly, or a lot of my patients are very impulsive and maybe will say things without thinking that can lead to difficulties. They may become distressed during unstructured times, and they do find unstructured times, again, break times, lunch times, after school activities, possibly PE, can be quite difficult. They might try to direct the play of others, again, trying to control things because that helps them feel better and feel less anxious. So they can be, you know, they can try to direct the play and take charge a little bit. So quite often are being described as being bossy or controlling, and that's not what they're trying to do. It's just about helping themselves feel a little bit better. They might have difficulty with group activities, cooperative activities that I already mentioned. They may have difficulties playing with, or they might like to play, with younger children or seek out adults. And we see that a lot, actually, that they find that easier, that they, you know, adults are much clearer maybe in their communication, and that's more reassuring. And the younger children, they can kind of help to look after them, and again, that makes them feel better. They understand their communication skills better because maybe they're at that developmental stage themselves. So quite often that can be an indicator for us when we're making an assessment. They might refuse to enter busy environments such as parties because, again, that's just so overwhelming for them, and it's just important to try and think about what that's about. It could be that they are struggling with the social side of that, but also some of these busy environments, thinking back to the sensory side of things, it might be that it's overwhelming, so we have to unpick that a little bit. So how that kind of might, or what that might mean, is that they might have difficulty with language and communication skills, whether it's non-verbal, verbal, or, you know, kind of any parts of that language they might have difficulties with. They might not understand the social rules. Sometimes there's rules that we just expect people to know, and we've never taught anybody. We think, oh well, they'll learn that by watching, and actually we've not been clear about it. So do they understand the social rules of that game, or what's expected of them in that situation, and are they able to use them in the right context? They might do they have the ability to take perspective of another? Can they see somebody else's point of view, or are they very black and white and very rigid and not able to kind of objectively look at another person's point of view? So that can, you know, that's a big task to be able to learn. That's a huge skill. Regulation of their own behaviours, they might not be aware of or have that ability to self-regulate, and I see that all the time in the patients I work with, is that difficulty with regulating their behaviours and impulses. So we work on that a lot. They might just not understand what the intentions of others have been, you know, and quite often I see that a lot with maybe more often with the teenage girls, right enough, but they do struggle with that kind of social relationships, and girls can be horrible to each other, especially in secondary year, but they don't know why, and not being able to understand why maybe somebody behaved in a certain way. And they might struggle to adapt, you know, to a certain different context and be flexible. They may struggle with their emotional literacy, being able to explain their own emotions or to recognise how they actually feel, and again, to regulate those. And sometimes they can go from 0 to 100 in 0.3 of a second, and you think, where did that come from? But actually, things have built up gradually over the day, you know, like we talked about with the Coke bottle effect. And you might not have seen it because it might have been sensory things, there might have been difficulty with communication, there might have been difficulty with all of these pieces of pie, and then you see that reaction happening and they can't regulate it at that point. And they maybe are not motivated to interact with others because they find it difficult, or maybe they're trying too hard. You know, we can go from one extreme to another. Quite often my patients try too hard, and they're, you know, they'll give them everything. They'll give them their bike and they'll give them their iPad, but it's about they're, you know, trying to kind of make those friendships because they struggle. And anxiety around lots of things like maybe eating in social areas and all of these things as well. So we just need to think about what could be going on and what can we do to help in these situations as well. We can offer lots of reassurance and acceptance, and that it's okay because it's difficult for them. So we need to kind of reassure them and approve and accept that things might be difficult. And we can maybe try to help them to change those patterns, but we actually have to accept that that's hard for them. We can model what those reactions look like and interactions look like, and that's a really good way for young people to learn. You know, that's how we learn to walk, how we learn to talk, so we need to model those interactions, and especially now when we haven't been having the opportunity to mix with people as much as we did pre-COVID, and that's going to start again now. But you know, they have missed a lot of social interactions that we would have expected in the last 2 years. We want to encourage peer support and see if you can build on those friendship groups and help them to learn from each other as well, and cooperation. Social skills groups, for example, are fantastic for helping young people with these difficulties. We might target skills through structured one-to-ones with parents, or maybe one-to-twos with siblings as well. And we can rehearse social situations and, for example, social stories. And again, Rachel, you can keep me right, but on the Pines website there is a video on social stories. Am I correct?
Yes.
Yeah. So honestly, you really need to go onto the Pines website, because if you're recognising any of these areas of difficulty, there is usually something there that will help you to think about that and what you can put in place to support. We might have to make social rules explicit. You know, we might think that everybody should know what's expected, but do they understand that? And make sure that we're repeating that, because quite often they can forget, so we need to reinforce it. Provide structured activities at times that they find difficult. So if there's going to be a family party, can you do something to make that a bit more structured, that they've got things to do so that they don't feel as anxious and out of control? And we want to kind of, I suppose, praise and cultivate positive emotions and look for the positives and build self-esteem and confidence, and avoid labelling and, you know, kind of making them feel that what they're doing is not the normal or or whatever anybody's perceptions is. But you don't want to make them feel that they are different, that it's different. They might perceive the world differently, but that's not necessarily wrong. So we need to think about just how they perceive the world, and that that's not being looked at in a negative way from anybody who's involved. Rachel, I think you're on for the last one.
I am, yes. So this is the last slide, folks. You know, if you've coped with all 5 bits of that pie and your difficulties within the first 5 pieces, it's going to have a knock-on effect on your emotional functioning, and this can be incredibly difficult for kids with neurodevelopmental difficulties. So you might have some pretty extreme emotional responses. So this tends to be the kids that I work with a huge amount, who are really struggling with their emotions and how they manage them and how they explain them to people. So they often present with behaviour that's out with the norm. They don't know how to talk about it. They feel very, very anxious. They get very distressed at times, or they withdraw into themselves, and that's incredibly difficult for young people, and they need a huge amount of emotional support in order to be able to learn how to express those emotional needs. So the profile of that child is that they may be really struggling with friendships. They may really struggle to show empathy, although I hate it when people say that kids with autistic kids are not empathetic. They are. They might just be really struggling to explain it and to understand it and to show what you would need to show for that other person. They might really understand. Excuse me, I can't get my words out this morning. They might really struggle with those unspoken social rules that Lesley was talking about. You know, we have lots of intrinsic rules that we don't really talk about, but everybody follows, that aren't actually taught. Well, some children with neurodevelopmental difficulties need to be taught those rules in very specific ways. They may really struggle with instructions or with finding when things change because of those executive functioning problems or flexibility of thought problems, staying on task. They might be having overwhelming sensory experiences. So when I'm asked to work with a child nowadays who's got significant emotional problems, I will always look at their sensory profile as well, to look at what we can do to help them to feel better. And this is probably going to have an impact on their diet, and so they could overeat or undereat, and there might be some sleep disturbance as well for these kids who are really struggling with their emotions. So we need trusted adults to be really attuned to that child and to understand what that child's needs are and how we can best meet them. We need to have a really consistent approach. We need to model some emotions of language and help them to understand what the different emotions mean. We might need to reduce stresses by managing the environment much better and in improving our communication with them. So, for instance, I'm currently working with a little girl who is not managing to be in a mainstream class. So her base for the day was the library. But actually, when I did a SOS3 profile on her, I found that she's got absolutely incredibly high visual stress. So being in the library was extremely overwhelming for us. So we've moved her to somewhere else within the school building, and it has made a massive impact within the first few days, it made a massive impact. We might use things like self-regulation scripts, which are talked about within the film for the emotional piece of pie. We might use social stories and comic strip conversations, and as Lesley says, there is a film specifically about social stories and comic strip conversations on the Pines website. And we might also need to consider diet and sleep, because if you're not eating right and you're not sleeping, that's going to have a massive impact on your ability to function. Okay, also on the Pines website, we have our amazing dietitian Dave Rex has done a series of films around diet, and there is also a film done by one of our Sleep Scotland counsellors, Sarah Hewitt, around sleep difficulties and how you can manage those sleep difficulties. So that's the end of our presentation today.